Hello and welcome to week 5 of the Principles of Exercise Therapy, PET. And this week we're dealing with balance and proprioception. And you can see an impressive balancing act of a young lady balancing on top of a bottle. Don't try that at home. So our centering slide is about physiotherapy. Why do we have this slide? It just reminds us what our profession is about. It's about anatomy and physiology, movement and function, maximizing wellness potential, minimizing disease and injury, and solving real-world problems. So our principles of exercise therapy, remembered by Asport Billy. We've got adaptation, specificity, progression, regression, overload, reversibility, time out. Then we've got behavioral change, individuality, lifestyle integration, law of diminishing returns, and your responsibility. The most important, obviously, being your responsibility. So in this session, by the end of this lecture, you should be able to describe the concepts of balance and proprioception, gain insight into how balance and proprioception can be used in clinical practice, and apply balance and proprioception to your patient scenarios. So let's start with sensation of movement, or kinesthesia. So movement is our way of interacting with the world. Movement is life. So all communication, speech, gesturing, sign language, writing is mediated by our motor system. So effectively, movement is our means of communication. The brain uses sensory signals from the body's sensory receptors to determine future actions. And kinesthesia is the sense of body motion. Kinaesthetic learning, learned by touching and doing. So sensory neurons are your receptors. They're chemoreceptors. These detect changes in the chemical environment. So if you were sprinting up a hill repeatedly, you get lactic acid in your quadriceps. With that increase in hydrogen ions, all that's happening is your chemoreceptors would register probably a little bit of pain. And then you've got thermoreceptors. They detect whether you're hot or whether you're cold. Photoreceptors in the retina of the eye, and these sense changes in light. Auditory receptors, obviously the inner ear, they sense vibration of sound waves. Nociceptors, these sense noxious stimulus, as opposed to pain. So let's just delete that. More noxious stimulus than pain. And then you've got mechanoreceptors, and these detect changes in pressure, in touch, in distortion and stretch, such as the stretch reflex that we'll come on to a little bit later. So we've got an integration of sensory input and motor output. So senses take information to the brain from the senses, and then the brain tells the movement what it wants to do. From the brain to the spinal cord, down the nerves, into the muscles, and we've got that movement created. And this diagram shows, so you've got a stimulus, then you've got a controlled condition, you've got receptors, you've got the control center, the effectors, and the response. And this is it in a homeostatic loop. That loops over and over again. So the diagram used there is the stretch reflex. Responses to change. So the brain's response to the sensory stimuli results in its future movements, and these may be neuronal reflexes, like fast, predictable movements, autonomic responses to changes in the environment, or appropriate amounts of muscular work needed to perform a task. For instance, recruiting more motor units when you're trying to open the lid off a jar or that's a bit stiff. So these are both constantly influenced by your proprioceptive receptors, your muscle spindles, and the GTO, which is the Golgi tendon organ. So the muscle spindle itself is a specialized grouping of muscle fibers found within skeletal muscle, and it's going to monitor the changes in length of a muscle by responding to the rate and the degree of change in length. So that's the speed, and the degree. That's important to changes in length. And the muscle spindle detects a stretch to the agonist, that's the contracting muscle, which is transmitted as an action potential along the sensory nerve, which is the afferent nerve. Okay, this sensory nerve synapses with the motor nerve, the efferent, and an impulse is transmitted to the agonist muscle to contract. And there you've got a diagram of that. So the stretch reflex. Muscle spindles detect stretch in the muscle. So sensory neurons conduct action potentials along the spinal cord. Sensory neurons synapse with the alpha motor neurons, and stimulation of the alpha motor neurons causes the muscle to contract and resist being stretched. Okay, you can see that feedback loop with what's going on from the spinal cord down all the way down to muscles. So spinal cord, okay, sensory neurons as well, and this just loops over with that particular reflex. So here we are. This is a tendon. Okay, this is the muscle. Okay, and this is the Golgi tendon apparatus, which is more towards the tendon side of things as well. The nerve fiber of the sensory neuron. Okay, that's detecting a particular stretch. And here we've got the muscle tendon junction for tension, and then we've also got the relaxation response as well. Again, everything's synapsing, going through the spinal cord very fast. So we've got pressure receptors. We've got different types of pressure receptors. You've got ones here, okay, so free nerve endings to sense pain, heat and cold. Then you've got ones that are wrapped around, such as like hair and touch. Okay, then you've got the Merkel discs. They respond to light touch. Okay, and then Messner's corpuscles, again, these also respond to light touch. Okay, then you've got Pacinian corpuscles. They respond to strong pressure, and there's something called the pain pressure threshold. Okay, and then you've also got the Ruffini corpuscles, and they respond to continuous pressure. So it's important to know those different types of senses. So sensory motor control, we've got a complex set of sensory motor control systems that include sensory input from vision, proprioception, the vestibular system, and the body's ability to balance. Balance is that center of mass over our base of support. Okay, so we've got the sensory input, vestibular, visual, proprioceptive. Then we've got the integration of the input, okay, to do with the cerebellum, okay, and the cerebral cortex, and also the brainstem. Then we've got the motor output, okay. So for the vestibular system, it would be the vestibular ocular reflex. Okay, for vision, it's going to be motor impulses that control the eye. Okay, and proprioception is going to be motor impulses that make postural adjustments, and everything ties together for balance. Okay, so there's three systems working for balance. So balance is the ability to maintain a line of gravity over the base, within the base of support with minimal postural sway. Okay, sway is the horizontal movement of the center of gravity when a person is standing still. Okay, so when you can stand still on something that is nice and solid, like some concrete, you get minimal sway. I imagine if you're standing on top of that bottle, you're going to get maximal sway, which is why the photo is impressive. So maintaining balance. We maintain balance as part of coordination of input from multiple sensory organs. So the somatosensory system, and this senses proprioception and kinesthesia of the joints, knowing where the joint is. Okay, then we've got the vestibular system, and that regulates equilibrium and our position of the head. Then we've got our visual system. That's the position of the head in relation to the body in space. Okay, and then we've got our senses, and our senses detect changes to the body position with respect to the base of support, regardless of whether the body moves or the base moves or changes in size. Okay, so all these systems contributing to balance. So we've got dynamic balance. Here you can see the legendary Johnny Wilkinson, England number 10, and he's changing his balance as he gives Dan Carter the slip, I think, there. So it's that adaptation to movement and external environment, like Johnny Wilkinson doing the side step, okay, and it's similar to like an elderly lady stopping herself being blown over by the wind. It's that type of thing. So the vestibular system, we've got two types of sensory organs, okay, the otolith organs and the semicircular canals. The receptor cells send signals through the vestibular nerves to control eye movement, posture and balance. The vestibular system detects motion in the head in space to generate reflexes that are crucial for stabilizing the visual axis, maintaining head posture, our subjective sense of movement and our orientation in space. So we've just tilted that to the slide. Okay, so we've got the higher centers that would control spatial orientation. We've got eye muscles that stabilize your gaze, and we've got the spinal cord motor neurons that stabilize your posture. So the visual system. So sensory receptors in the retina are called rods and cones. When light strikes these rods and cones, impulses are sent to the brain to provide visual cues, identifying how the body is orientated relative to other objects. So how are the vestibular and the somatosensory sensors linked? Okay, so the somatosensory system is about proprioception and kinesthesia, and these inform the movement and position of different body parts relative to each other. So important sensory information from the neck and the ankles provides essential proprioceptive cues to indicate the direction the head is turned and the body's spatial position or the sway relative to the quality of the standing surface, if that's like a hard concrete surface or if it's a more difficult uneven surface. So proprioception is the sense of relative positioning of parts of the body and the strength of effort being used in movement, okay, from the Latin proprius, okay, meaning one's own individual perception, okay. Proprioception enables us to recognize the location and rate of movement of one body part in relation to others. It allows us to estimate the weight of objects and determine the muscular work needed to perform a task and judge the position and movement of our limbs without using our eyes, and is something called joint position sense. Okay, so we've got a demonstration of this on the next slide. So what I want you to do is I want you to close your eyes. Okay, with your right arm, okay, what I want you to do is move it about until you created a different type of shape with angular joints at your shoulder, your elbow, your wrist, your fingers and your thumb. Okay, that's what I want you to do. Okay, so how many different types of arm position can you get into? The answer is infinite numbers. Okay, because your arms move in so many different directions as well. So what I want you to do now is lift your non-dominant foot off the floor, put your arms above your head, close your eyes and count. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, open your eyes. If you've done that, okay, you've got pretty good balance. If you can make it past 30 seconds, that's impressive. So proprioceptive receptors. Many receptors feedback proprioceptive information. Receptors which provide this feedback are found in the skin, in the bone, the ligaments, the joint capsule, the tendons and the muscles. So if one is impaired, others need to be facilitated to compensate, such as vision or loss of sensory input after 24 hours of an injury. So what happens is that if you roll your ankle, you've got a big fat swollen ankle, you don't really know where that ankle is in space. Okay, after 24 hours you've lost that proprioception and that's when the joint is more vulnerable. So instability and proprioception. So instability can be divided into two. Mechanical or true instability. So there's actual damage to the soft tissue, tear or rupture or a fracture, and that requires passive control, like a brace or something. And then we've got functional instability. Okay, so healing is taking place, but there's a reduction in proprioception sensory feedback, which results in joint instability. This includes loss of sensory information about the joint because of inflammation of the nerves or capsular distension, and these all result in poor neuromuscular control. And we use this recurrent ankle sprain as a classic example. So conditions which proprioception is commonly reduced, so in any sort of trauma, rupturing your ACL, dislocating your shoulder, rupturing the ligaments to control your ankle. If you've got some sort of immobility or a hypermobility syndrome, okay, if you're over the age of 60, okay, or you're lacking in vitamin B12, if you've got OA, osteoarthritis, if you are intoxicated from alcohol, or if you have a neurological disorder. So the assessment of proprioceptive instability, we've got something called the Romberg test, okay, which we'll come on to into the practical. We've got the functional reach test, the Berg balance scale, the balance efficiency scale, the POMA, the performance orientated mobility assessment, time to get up and go, the STAR excursion test, and we've got center of pressure on a force platform. All of these are measuring proprioception. So the aims of treatment, okay, early afferent input from a joint. Okay, according to Chan and Vicenio, okay, in 2003, we've got to get, okay, that proprioception back restored to the joint as soon as we can. We've got to restore the reflex stability. We've got to restore normal neuromuscular control and enhance the neuromuscular response. So progression. We've got to progress to function. It's no good just giving some ankle waving exercises if we're not progressing them into functional activity and functional movement. So we could do that by reducing or removing the visual stimulus, such as closing your eyes. Okay, we can alter the base of support, okay, going from 2 legs to just 1 leg. Okay, that clearly alters the base of support. Okay, and then you've also got some sort of perturbation, okay, where you're effectively just wobbling the person as well, or you're causing them to have to change their balance. Okay, we could increase the speed, okay, or simply change the speed. You could add a ball, or you could introduce plyometrics. So by the end of this session, you should be able to describe the concepts of balance and proprioception. You should have gained an insight into how balance and proprioception can be used in clinical practice, and you should be able to apply balance and proprioception to a patient scenario. Thanks for listening, and we'll see you in the next podcast.